Hello and welcome all to the first official online webinar, the basic module in infectious diseases, organized by the Infectious Disease Forum of the Federation of Clinical Pharmacists in India. Hi everyone, I'm Fatima Shemin, one of the member of the ID Forum of FCPI. Today I'll moderate the session. So before we begin, I would like to give you some instructions. Firstly, feedback form will be available below the video thumbnail on the FCPI website towards the end of the session. Secondly, certificates will be given within 17 days of submitting the feedback forms. If you're facing any issues, we would love to hear from you. So feel free to contact us for any assistance through the email ID provided in the website. And if you have any questions throughout the webinar, please write them in the chat section or you can directly email it to us. I hope the instructions are clear. So today's topic is microbiology and antimicrobial resistance, focusing gram-negative bacteria. We'll hear from one of our expert speakers, a member of the Infectious Disease Forum. Welcome, Sangeeta Sudhir. You can take it from here.
Thank you, Fatima, for your kind introduction and a very warm good evening to one and all. First of all, let me express my sincere gratitude to the board of members and the committee team members, organizing committee team members for organizing this event. So on today's topic, we will be discussing on the basics of microbiology and antimicrobial resistance of gram-negative bacteria, especially focusing on Enterobacteriaceae. So we will be discussing why we are focusing on this GNB and especially on this Enterobacteriaceae, the basics of microbiology, the classification, characteristics, differentiation, its clinical importance, and a short insight onto the AMR. So why we have selected GNB, it's mainly because, as you all know, as per the recent reports, the antimicrobial resistant rates are having a huge burden. Like it's made basically because of these Enterobacteriaceae. So as you can see from this global antimicrobial resistance surveillance rates, the carbapenem resistance among the commonly seen Enterobacteriaceae like Klebsiella is very, very high, especially in the low middle income countries. It's around 30 to 60%, whereas the resistance rates to the third generation cephalosporins are around 80 to 100% among these low middle income countries. And this is actually a very huge burden that it should be taken care of. So that's why we thought of starting with this basic module with the Enterobacteriaceae. And as per the CDDEP country level data in India, we are having a high resistance rate. As you can see, the E. coli, it's around 18%, Klebsiella 59%, and Enterobacter 46%. So this is actually alarmingly very, very high. So let's start with the basics. So as you know, let's start with the gram-negative bacteria. So whenever a patient comes to a clinic, when we get the clinical specimen, first thing what we do is to identify if it's really an infection or is it a non-infective etiology. And then we'll be assessing if it's really a viral infection or it's a bacterial infection. Once we decide it is a bacterial infection, next thing what we need to know if it's a gram-negative or a gram-positive infection, right? So what we do for that? How can we assess it? Based on gram stain. So gram stain will help us to determine if it's a gram-positive or a gram-negative bacteria. So this we have studied in our lower classes, like in the gram stain, if it is purple in color after the gram stain, after the acetone wash, if it's retaining a purple color, then that means it's a gram-positive bacteria. And if it is retaining, if it is getting washed out and retaining a pink color, then that is a gram-negative bacteria. And why is that? Because it's because of their peptidoglycan layer. And it's not just because, and it's not just the difference between the color. There are a lot of other features like So the gram-positive bacteria has a thick peptidoglycan layer, and gram-negative has got a very thin layer. That's why this color retention is being different. Okay, and apart from that, gram-negative bacteria has got two outer layers. Presence of lipopolysaccharides, presence of porins, and through this porins, all the nutrition will be receiving to the gram-negative bacteria, and then presence of teichoic acid in the gram-positive bacteria, as well as they produce exotoxins, whereas gram-negative one will produce endotoxins, and a lot more difference. So you can read about it from lower class texts. So once we identify that this is a gram-negative and gram-negative bacteria, next thing what we need to identify what species these organisms are, right? So we start from here. So GNB rods, once we get it as a GNB rod, next thing what we need to do is to assess what type it is. So first, for example, we can do it in a McConkey medium. We can culture it in a McConkey medium. And then we will be assessing if this is a lactose fermenter or a lactose non-fermenter. So lactose fermentation means it is the ability of that organism to convert lactose into lactic acid. And when they are cultured in a McConkey medium, the lactose gets converted to lactic acid, it becomes more acidic. That medium will become more acidic. Its pH decreases and will turn out to be pink in color. Okay, so if it turns out to be pink in color, then that means it's a lactose fermenter. Or if it becomes an off-white, cloudy color, then opaque color, then it's a lactose non-fermenter. So we assessed it as a lactose fermenter. So basically, McConkey medium is usually used to assess this GNB. Next thing we will do is oxidase test. So this is an example of how we do an oxidase test. As you can see, this is an oxidase disc. If an organism is growing inside this culture media, and if you are dipping this oxidase disc into this medium, if the organism has the ability to produce cytochrome oxidase enzyme, then this disc will turn into purple blue color within 30 seconds. So in that case, it is an oxidase positive. But here, for all our Enterobacteriaceae, they are oxidase negative. That means they are organism which doesn't have the ability to produce cytochrome oxidase enzyme, and they are also lactose fermenters. So hope that's clear. So this is how we identify an Enterobacteriaceae, and these are the common Enterobacteriaceae that we see. Okay, and we are going to discuss more about this Klebsiella and E. coli. And as you can see, there are others, lactose non-fermenters like Acinetose, Stenotrophomonas proteus, and this is how we identify these organisms. Hope this was clear till now. Now let's talk about the major characteristics. So all of these Enterobacteriaceae are normally residing in intestinal tract of either humans and animals. So they are called as coliforms. They are facultative aerobes or anaerobes, that they can survive with or without oxygen, and they have the ability to produce catalase enzyme. Okay, they are catalase positive. And this we assess. Catalase means it is a self-protection mechanism for the bacteria where they get protected from the hydrogen peroxide that is released as a metabolic byproduct of oxygen. Okay, whenever this hydrogen peroxide is released after the oxygen metabolism, it gets converted to hydrogen and water through this catalase enzyme. So it's a self-protection mechanism by the bacteria, and they are positive. This GNB are catalase positive. And this we identify through catalase test, which shows the production of, it is it is characterized by the production of bubbles in the medium. And next, lactose fermenter. So mostly these are carbohydrate fermenters, and they produce acid and gas. These are oxidase negative. As I already said, they don't produce cytochrome oxidase enzyme. And all of these things we assess it through oxidase test, McConkey medium test, in the McConkey medium, the catalase test. Then next important feature is reduce nitrate to nitrite. So you may have seen in many urine routine, patient will be having numerous pus cells, and nitrite will be positive. Okay, nitrite positive. So that means it is suggestive of Enterobacteriaceae. It possesses complex antigenic structures. Okay, there are many strains like H antigen, O antigen, K antigen. All of this determine these complex antigenic structure makes them more difficult to get treated, and it also determine their virulence, the severity of the illness. It produces endotoxins and virulence factors, and some of them are motile and non-motile. And these are some characteristic differentiation between E. coli and Klebsiella. Both of them are rod-shaped. They are non-spore forming. They both are lactose fermenters. They both are facultative anaerobes, catalase positive, oxidase negative. Another feature is E. coli is indole positive, whereas Klebsiella is indole negative. It means that they have, if these are, they have the ability, this E. coli has the ability to reduce tryptophan, okay, degrade tryptophan, and this will turn out to be red in color, okay, in the outer layer. It becomes red in color in the outer layer. So that means they are indole positive. If it becomes slightly yellowish in color, then that means they are indole negative. They will not degrade tryptophan. So Klebsiella will not be doing, whereas E. coli is indole positive. And another feature is that E. coli, when cultured in the medium, they form circular, convex, smooth colonies, whereas Klebsiella tend to be mucoid. They they become coalescence upon prolonged incubation. We'll discuss it in further slides, the coming slides. So apart from that, there are various other tests as well, like indole, as I already said, indole test, Vox-Proskauer reaction, where we can identify the Klebsiella, Simmons citrate test, hydrogen sulfide test, both will be negative, urea hydrolysis, positive, then lysine decarboxylase, both will be positive, cellobiose fermentation, the Klebsiella will turn out to be positive, and there are a lot more. Okay, so just to give an idea, all of these tests are helping us to differentiate between each organism or all of these Enterobacteriaceae. So let's discuss these cultures. As you can see here, there is a gas production. Gas production means, as I already told you, both of these Enterobacteriaceae, Klebsiella and E. coli, are carbohydrate fermenters. They have the ability to produce acid and gas. So there are gas formation. They are lactose positive fermenters, smooth circular convex colonies. Sucrose mannitol fermentation is occurring. Now here there is a cellobiose negative. Cellobiose is negative. So all of this is suggestive of E. coli. And here you can see that there is also gas production. There are mucoid colonies, and upon prolonged incubation, they get coalescence together. So this is suggestive of Klebsiella pneumonia. So hope till now you got some understanding. Let's discuss some questions. So a 37-year-old woman with a history of urinary tract infection is coming to an emergency department with burning on urination along with frequency and urgency. Her urine routine showed numerous pus cells and nitrite positive. So what could be the possible organism? Can you give your response, please? So as I already discussed, it is nitrite positive, and among these four of them, the answer is E. coli. So it's a nitrite positive organism, right? Okay, next question. It's a 60-year-old female was diagnosed with hospital-acquired pneumonia and required invasive ventilation. Prior to starting a broad-spectrum antibiotic, sputum culture was sent for gram stain, and it showed numerous polymorphonuclear leukocytes and gram-negative rods. The microbiologists identified that gram-negative roots have a capsule. The organism is a lactose fermenter on McConkey agar. It's a lactose fermenter and appears to be pink and mucoid forming. It is non-motile and lysine decarboxylase positive. What is the most likely organism? Please let us know your answers. So it's the lactose fermenter on McConkey agar, pink and mucoid forming. They are non-motile and lysine decarboxylase positive. It is definitely not other organism, and here it is a lactose fermenter and it is a non-motile and pink and mucoid forming. So it is definitely Klebsiella pneumonia. Okay, thank you. So let's move on to the clinical relevance of these organisms. As you can see from this picture, this is the picture of this is the normal bacterial flora in a person in the community, a normal healthy person in a community, whereas this is the bacterial flora in a person admitted in a hospital or a long-term care facility. As you can see, as I already said, these Enterobacteriaceae, Klebsiella and E. coli are coliform bacteria. They normally reside in the intestinal tract in a normal gut microbiota. But when the patient, due to many other risk factors for a patient, it can be many things like patient is compromised or patient has been admitted for a prolonged period due to multiple exposure to other factors. These organisms can translocate to other anatomic sites as well. So once the host defense mechanism get compromised, these normal gut microbiota, not normal gut microflora, can become more pathogenic. Okay, and that is how we get infection from this. So basically, E. coli helps us. E. coli is a normal organism in our body and helps to provide nutrition. But Klebsiella is mostly seen, although it is seen in the gut microflora, they have the ability, they are more pathogenic. Okay, and they are usually seen as pathogenic organism. So these are transmitted through various routes. So human to human, vector to human, through environment. Now, as I said, normal flora translocation to other anatomic sites. And basically, these are transmitted basically because of the poor infection control prevention practices. Okay, in hospitals. And that's why the hospital-acquired infection rates are very high. The morbidity, mortality is very high, and this has got a significantly emerging resistance rates. So through ventilators, through tap waters, through the transmission between person to person, ICU, and a lot more. Now let's discuss some of the clinical pathways. So till now we have been discussing how to differentiate these organisms through microbiology methods, and it is not just the methods like microbiology methods. The differentiation, if it is a real pathogen, if it is a real species that's causing the infection, we have to assess it through multiple factors, and that is where the clinical pathway plays an important role. So when a patient comes with signs and symptoms, first thing, as I already told you, first thing what we assess is it really an infective or non-infective etiology. Sometimes patient may not have an infection, like if it's an eczema, then it need not be an infection. Next thing, is it really a viral or a bacterial infection? If it's a pharyngitis or a bronchitis, it need not be a bacterial infection. Okay, so we will be assessing if it's really a viral bacterial. Then we'll be assessing if it's a GNB gram-positive that already mentioned. But along with that, we should also assess what is the site of infection. So if it's an infection in the GI tract, then we can consider a gram-negative bacteria. But if it's an infection in the skin and soft tissue, then we should consider it as a gram-positive bacteria. Other laboratory parameters like WBC, CRP, procalcitonin. If the procalcitonin is high, then we can consider it as a gram-negative infection. Now, other radiologic investigations, like if there is any consolidation, cavitation, or infiltration, if the site of infection is the lungs, or maybe some other things like ultrasound, etc. Then gram staining, cultures. So all these factors has to be considered before ruling out that this particular organism is causing that infection before starting an empiric antibiotic. Hope that's clear. Now let's discuss some of the infections, a common infection caused by these common organisms, like E. coli. So to speak about E. coli, you may have seen in your hospital antibiograms that the common isolates seen in urine antibiogram, the common isolate will be E. coli. In most cases, it will be E. coli because that is one of the common cause of UTI. And these are uropathogenic E. coli. They have got O antigen and they produce hemolysin and facilitate the tissue invasion. Then another strain which has K antigen has the capability to ascend and develop into pyelonephritis. There are other difficult to treat strains, O25, BST 131. These are also more pathogenic and has the ability to develop into more resistant strain. Another important one is E. coli causes this diarrheal disease, gastroenteritis. Gastroenteritis is different and diarrheal disease is different. And there are different types of strains. You may have learned in your lower classes like enteropathogenic E. coli. This causes severe watery diarrhea, vomiting, and fever. Enterotoxigenic E. coli. This is similar to the traveler's diarrhea. And usually we can see the outbreaks in nurseries for children less than 5 years of age. Shiga toxin producing E. coli, there are Shiga toxin 1, Shiga toxin 2. So these are more fatal, this cause these can cause hemorrhagic colitis, hemolytic uremic syndrome, acute renal failure, microangiopathic hemolytic anemia, and thrombocytopenia. Then there are enteroinvasive E. coli. Again, it's a type of traveler's diarrhea and foodborne diarrhea. Enteroaggregative E. coli, this causes chronic diarrhea with more than 14 days of duration and similar to the Shiga toxin producing E. coli. Then comes sepsis. And usually in children, neonates, they lack IgM antibodies, and when these infections, these organisms can easily cross the blood-brain barrier and cause, that's for meningitis, sorry. This can cause sepsis in infants. Similarly, same in infants, something that exhibit K antigen, this can ascend to the blood-brain barrier and cause meningitis and further leads to sepsis as well. So all of these are some of the common infection that we see due to E. coli. Coming to Klebsiella, you may have noticed in your hospital antibiogram, Klebsiella will be one of the most common organism coming up in respiratory fluid, especially in Indian setting. So in our hospital, we have seen such cases. So Klebsiella was one of the most common organism. So it causes pneumonia and bacteremia, UTI, etc. So all of these are some basic information that I would like to give you. So Klebsiella is one of the most potentially dangerous antibiotic, very difficult to treat organism because the emergence of resistance is very high among Klebsiella. So you can see ESBLs and ESBLs. ESBLs means extended spectrum beta lactamase producing Klebsiellas. They produce beta lactamases and they become, when they produce beta lactamase, if they are producing beta lactamase enzyme, That means they are resistant to first generation, second generation cephalosporins, penicillins, and we have to rely on beta-lactamase inhibitors like amoxicillin clavulanate, ampicillin, sulbactam, etc. Now, carbapenemase producers. That means they are producing some carbapenemases, and so that means none of the carbapenem is effective against this organism, like meropenem, doripenem, imipenem. If any one of the carbapenem is not active, not sensitive to these particular organism, then that means that is producing some carbapenemase enzyme, and we may have to rely on higher antibiotics like colistin and digicyclines, like this. Now, other Enterobacteriaceae, we'll just discuss other Enterobacteriaceae as well, like Enterobacter. These can produce pneumonia, UTI, device-associated infections, and Serratia and Enterobacter. These are not commonly seen as a normal gut microflora. They are mostly opportunistic pathogens. It can cause device-associated infections. So usually seen in patients admitted in hospital and long-term care facilities. So Serratia can lead to pneumonia, bacteremia, and endocarditis. And this is often resistant to aminoglycosides and penicillin, and usually treated with third generation cephalosporins. Proteus is another species that is seen in urinary tract infections. It can also cause bacteremia, pneumonia, contaminated infusions. So this has the ability to produce urease, causing hydrolysis of urea and release ammonia. They are highly motile, and this is usually treated with aminoglycosides or third generation cephalosporins. So you can read a lot about this after the session, so you will get to know things in detail. So apart from that, I would also like to give you some insight onto the common sites of infection. So these Klebsiella and E. coli are some common etiologic pathogens causing these infection in these sites. So basically, it is seen in osteomyelitis, mastitis, brain abscess, meningitis, otitis media, even in the eyes, the corneal keratitis, then coming to the gallbladder infections, in GI infections, traveler's diarrhea usually is caused by E. coli, then genital tract infections, endocarditis, septic arthritis, urinary tract infection, hepatic abscess in lungs, pancreatic abscess, spontaneous bacterial peritonitis, and sinusitis, especially the E. coli in patients with diabetic ketoacidosis and neutropenia, burn wound sepsis, decubitus ulcers with sepsis. I have adapted these from the Sanford guidelines. And I would also like to give a short insight onto the basic susceptibility pattern of E. coli. So this is the typical susceptibility pattern, but for different strains, for different resistant strains, the pattern will differ. So this is similarly in Klebsiella. This is the normal typical pattern, but if it's ESBL, then all of these first generation, second generation, third generation cephalosporins won't work. The penicillins won't work. We may have to rely on this piptaz and ampicillin sulbactam. If it's a carbapenem, CRE, carbapenemase producing Enterobacteriaceae, then we may have to rely on higher antibiotic like colistin and fosfomycin. So these differs. So let's talk something about carbapenem resistant Enterobacteriaceae. As I already said, resistance to at least one carbapenem, or if the organism is producing a carbapenemase enzyme, then that is considered to be a CRE. So these are some of the common carbapenemases: KPCs, New Delhi beta-lactamases, metallobeta-lactamases, NDMs, Verona integron encoded metallobeta-lactamases, VIMs, imipenem hydrolysing metallobeta-lactamases, IMPs, OXA48, etc. So in India, usually, as per the reports, it is said that the NDMs, co-production of NDMs and OXA48 is comparatively more rather than the KPCs. NDMs and OXA48 are more in India. Now, these are carbapenemase enzymes. So any of this has to be there, or we can also assess based on culture sensitivity if carbapenem is any one carbapenem is resistant, like Mero or Dori or imipenem. There are other mechanisms if it's a carbapenemase non-producing, it need not be the same resistance pattern due to the outer membrane porin disruption or due to the amplification of certain genes. So this is another mechanism by which the Enterobacteriaceae become CRE, carbapenem resistant. And how can we assess this carbapenem resistant Enterobacteriaceae? There are various tests to differentiate between these carbapenemase producing and non-producing strains, like phenotypic test, modified carbapenem inactivation method, carba-NP test. And we can further differentiate these strains like OXA48 APC through molecular testing methods. So just to wind up, why these resistance is emerging? Mainly because some of the risk factors. Okay, so patient will have a prior antibiotic exposure, which will be inadequate. The patient might have got an inappropriate empiric antibiotic therapy, or patient may have a prolonged stay in a hospital, or it may be due to poor infection prevention control practices, or it could be prolonged hospitalization or inappropriate empiric therapy. So all of these are common risk factors for the selection of resistance. So from today's presentation, we just wanted to give you some basics of what the microbiology of GNB routes are, what are the various strains, what are its just the basic clinical relevance, and a brief insight onto the emerging antimicrobial resistance. And in the upcoming sessions, we will be discussing a lot more about this Enterobacteriaceae and how this is managed, especially the antimicrobial stewardship approach. Hope it was clear to you. These are the references we have. These are the references from which we have adopted the contents. And thank you so much for your effort and patience and time. So now it's open to questions, and you can definitely mail us if you have any further questions in this mail ID. And thank you so much. You will be getting certificates for the session after 7 days.
Thank you, Sangeeta, for this wonderful session. I think we can take some questions now, if you're ready.
Sure.
Okay, so we have a few questions for you. So first question is gram staining clinically important for initiating or changing an antibiotic?
Definitely. Because as I already mentioned, if we need to understand if it's a gram negative or a gram positive bacteria, gram staining is essentially important. And if we are starting, and it can, as when a patient comes with an infection, and if we are understanding, and we are starting with a broad spectrum coverage, including both gram positive, gram negative coverage, as we get to know the gram staining, as we get to know the results of gram stain, we can lower it down. We can just tailor it down to just gram negative coverage. So definitely it's very important.
Okay. So second question is how to identify CRE and ESBL from culture and sensitivity reports alone?
So just as I already mentioned, If it is an ESBL positive, usually what we do is we will assess the resistance pattern of third generation cephalosporins like ceftriaxone. So if it is sensitive, if it is resistant, then we should definitely consider it as a ESBL, and we will look at, we will be prescribing, we will be switching to BLBLIs. Whereas if it's a CRE, then it should at least be resistant to one carbapenem, doripenem, imipenem, or meropenem. And as I already told you, that this is basically in culture sensitivity. This is basically done through culture and sensitivity test. But ideally, there are other tests as well, like we will be assessing the carbapenemase enzymes. We will be doing molecular test or carbon-NP test. So that is how we do. But in limited setting, definitely we can do this way. And that's what we have seen.
Okay, so we have one more question. What is the role of beta-lactamases in antibiotic-resistant gram-negative bacteria?
Beta-lactamases so beta-lactamases means beta-lactamase is being produced by the gram-negative bacteria, and therefore all the lower antibiotics like penicillins, first to third generation cephalosporins are not being active. They get degraded, and therefore we have to rely on beta-lactamase inhibitor combination antibiotics like amoxiclav, ampicillin sulbactam, piperacillin tazobactam, cefoperazone sulbactam, etc. Hope I answered correctly.
Okay, we have one last question. It's from one of the viewers. In which condition is levofloxacin given as empirical treatment as monotherapy?
So in urinary tract infections?
Yeah, mostly in UTIs, right? Okay, so that's all for today. I hope the session was informative to everyone. Thank you, Sankita. Thank you, everyone.
Thank you so much. Thank you so much all.
Just want to repeat that feedback forms will be available below the video thumbnail on the FCPI website towards the end of the session, and certificates will be given within 7 days of submitting the feedback form. So if you're having any issues or if you're having any queries, please feel free to contact us through the email ID provided in the website, or you can see the email ID from the screen.
Thank you all.
Thank you.